Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hi, thank you for joining us for today's webinar, Wound Specialty Programs, a PDGM Diversification Strategy. My name is Molly Casey, and I'm on the marketing team at Axxess. Axxess is a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Today, you will hear from two Axxess experts, Shawn Hamilton and Tammy Ross. Shawn is a senior product manager for Axxess. She specializes in home health compliance and clinical operational excellence, with more than 25 years of home health and hospice experience as a case manager, clinical manager, director of nursing, assistant administrator, and clinical consultant. And joining Shawn is Tammy Ross, Senior Vice President of Professional Services at Axxess. Tammy leads a team of professionals whose goal it is to provide education as well as practical operational solutions to home health, hospice, and home care organizations. Tammy has spent 30 years in home health and has served as a senior executive of a large national home health agency. Before we begin, a few housekeeping items. Your phones have been muted, but you may submit questions through the chat function. We will follow up with you after the webinar to respond to any questions you may have submitted. Slides from today's presentation, along with the recording of the webinar, will be available afterwards and will be sent to all who registered via email. They will also be posted in the Axxess Help Center. If you would like a copy of the slides prior to then, you can find them in the handout section of the webinar today. They're posted there as a PDF. Okay, Shawn and Tammy, over to you.
Thanks, Molly, and thanks, Shawn. It's exciting to be presenting with you today. I am so excited to talk about this diversification strategy. Last year, several Axxessians kind of went on a road trip about PDGM, and we kind of projected what this year would look like. We got a lot of it very, very right, and our projections are playing out this year. There was one thing we didn't count on, that was COVID happening. So we're going to talk just a little bit about that as we talk about those elements around PDGM that affect wound care reimbursement. We'll talk about key components of a successful wound management program, and then we're going to learn how technology can enhance those wound outcomes. So let's take a little review of what PDGM looks like. I know everybody's used to seeing this graphic, but basically PDGM changed the way we did business. We went from a PPS role to a PDGM role. And in PDGM, we actually have four kind of huge building blocks. And that's the reason they kind of built this as a building block. The first being admission source timing, the next being clinical groupers, the next being functional impairment, and the last being comorbidity. We're going to look just a little bit closely at those determinants and see how they all mesh together to determine how reimbursement happens. So basically, the outcome information set, OASIS as we know it, has remained the same. No changes this year either, thanks to COVID. So that was a great relief for our agencies. But the thing that did change is that we moved from 60-day payments to 30-day payments. And if we look at those circles and how everything fits, the first building block that really starts building that HHRG rate is our clinical groupings. There's 12 of them. There's 2 timing options, 3 functional options, 3 admission source options, and 3 comorbidity options. All those work together to create that HERG. We're going to focus on that clinical groupings, that first 12. Well, let me show you something that happened this year in an impact analysis conducted by Dobson. CMS projected that this year there would be something called upcoding, and there would be something called LUPA avoidance. All of that was wrapped into what they called it behavioral adjustments. They said home health agencies would start coding differently. They would start having different primary diagnoses based on that reimbursement. They also thought that there would be kind of LUPA gaming, where we would actually do visits that we really didn't need to do in order to avoid a LUPA. But as you can see here, that didn't happen. This is from our first year's claims data of this year, the first quarter from January to April. You can see the line for endocrine is still the most heavily coded primary diagnosis. And endocrine's not really a huge payer source. And we look at the other ones such as wounds, and yeah, it went up a little, but it did not go up significantly. So what do we learn for this? First of all, there was no gaming going on, but also we had to consider COVID happened during this time. A lot of people wasn't looking to start a new IV program or a new wound care program. Let's look at those assumptions in more details on the next slide and see what the study actually told us when we drilled it down. When we looked at PDGM projections, CMS said it was going to be budget neutral. What actually happened, if you look to the right-hand side, is the Medicare spend rate was down by 21.6% in that first quarter, actually the first 4 months, January through April. And we know COVID hit in March and probably impacted that. In addition, that 4.3% decrease in reimbursement that happened to all of the agencies labeled as behavioral adjustments for upcoding and low utilization adjustment really didn't happen. If you'll see on the right-hand side, endocrine was still the highest grouper, and our LUPA was at an all-time high in March. It was 28.7%. And I'm sure many of you on the phone can really relate to this. March was at the peak of COVID. It was difficult to get staff into homes, impossible to get them into ALF facilities. So we had a huge LUPA rate. Unlike hospice, home health didn't receive that leverage and that grant to allow telehealth visits to count as a billable visit. So we did have very high LUPA rates. There's been no evidence of increased room programs in those first 4 months, but we really wouldn't expect that during the pandemic. That probably wasn't a time that agencies were looking to diversify and kind of grow that business line. That's why we thought now was very timely. We've learned to work within our COVID and our pandemic restrictions, and agencies are looking for ways to grow their business. And if you see here on our clinical grouping, you can see that wounds, their base rate is $1,422, one of the highest clinical groupings that we have, actually the highest clinical grouping. So it reimburses very well. We layer on top of that the admission source timing and the comorbidity adjustment and where that patient came from, whether a hospital or a nursing home. So you can see that top line revenue can be quite significant in a wound care program. So as we start thinking about building that wound care program, there's some building blocks that we need to look at. The very first thing is knowledge of staff. Home health kind of shied away from wounds for many years. In fact, that was one of the reasons that CMS actually said, you know what, we're going to change the way we reimburse agencies. They wanted a higher reimbursement for wounds. They wanted to incentivize agencies to take care of wound care patients and make sure they had the appropriate resources to do so. That tells me that they agree with my thinking that home is the best place to manage wounds. It's also the most cost efficient. So they really incentivized agencies, giving them that clinical grouping that reimbursed well. But unfortunately, agencies, many of them don't have wound care nurses. They wasn't doing as many wounds. So when you first look at your building block is, how am I going to educate my nurses? You can certainly use vendors to help do that education. There's also multiple online learning ways to do that staff education. but they need to know about staging, they need to know about treatments and measurements. And then what are you going to do when you need to get to advanced trained staff? How are you going to manage that? That's all things that you can look at. There's mid-levels, nurse practitioners, and PAs that are actually doing Part B billing for wound therapy. That's a consideration when you're thinking about your building block. The next thing to think about is efficiency, and something that Shawn's going to spend time talking to us about. Your electronic medical record needs to support a very viable wound care program, and it needs to have that clinical intelligence built in to help guide nurses and how to document wounds. We've kind of gotten rusty as we kind of got away from wounds in the industry. Not that we wasn't taking care of them, but we was not actively recruiting them. Also photos. You know, photos is a way that you can track wounds very easily. You can also get consultative visits based on photographs. So how are we managing photos? How are we keeping that HIPAA compliant? That's all part of efficiency. And then the last one I'll mention is supply management. We really have to watch our formulary, because even though wounds pay very well on the top line, we really have to watch those supplies as well as the staff and kind of balance how we're going to utilize both of those resources to actually still make a profit off a wound care patient, or at least break even. We don't want to continuously just lose money on wounds, kind of like we did in the PPS model. So once we get those two vital parts down, we look at visibility. We have to have visibility into what our wound program is. And there's ways of having that through business intelligence, risk stratification. Again, this is all built in our technology system. Are we able to look at that and be able to tell if we have a wound deteriorating? Are we able to make fast interventions so that we can make positive outcomes? Because remember, that's one thing that's going to be looked at in our OASIS is the ability to heal these wounds. You don't want to start a wound care program and have poor outcomes. So all that visibility is going to be necessary. And then lastly, we want to think about growth. If we want to build a wound management program, we have to grow that program, especially if you're looking to hire a wound specialist, wound nurse, WOCN or otherwise. That's a very expensive outlay for staffing. So how are you going to make sure that she has enough visits? It's by marketability. Who are you going to market to? Are you going to market to the hospitals? Are you going to market to ALFs? All of that is part of the growth that will support those positive patient outcomes. And I think, you know, using systems, EMR systems, so you can show your wound results in comparison to others is a great way to market your program. As we look at the next slide, we're going to talk a little bit deeper about that business intelligence. Here is just a way of tracking outcomes. Your EMR system should be able to allow you to track outcomes, or maybe one of your vendor partners. It'll help you to track healing rates. It'll help you monitor that risk we talked about. It'll help your nurses drive compliance so that you're getting those 4- and 5-star ratings. It'll help you to set internal benchmarks. You know, maybe you're at a 2- or 3-star now, but it's going to help you to benchmark your agency against your agency, and also benchmark nurses against nurses. You should be able to drive that down and find out, you know, which nurse has the best healing rates for wounds, because that's the nurse that you want to start with your program. And then obviously, you always want to be survey ready. One thing that I have learned, that where the money goes, so does the probe. So because wound care is being reimbursed at a higher level, you can suspect that you may have a probe on that at some point, especially if that's a new program and wasn't in your wheelhouse. So when CMS looks at that and all of a sudden your diagnosis are kind of changing around from maybe diabetes to pressure ulcers, that may trigger a probe review. So you want to make sure your documentation is definitely in place. The last thing I want to talk about is marketing your program. And when to market your program, we want to talk about things like improving patient comfort. Decreased time spent on dressing changes. No patient wants to, have a 2-hour-long dressing changes. Improve healing times. How do we prevent future complications? Do we need to use IV therapy in conjunction with our wound management? What are we doing about nutritional assistance? How are we making sure that we're encouraging that increased protein? How are we making sure that we increase those albumin levels? Are we offering ADL assistance? Are we teaching that as well? It's not comfortable to have a wound. What are we doing as far as occupational therapy, maybe to adjust the environment to allow pressure to be off of those wounds? Are we involved in social services? It's great for us to talk about high protein and for us to teach, things like, we want to improve your albumin level, but if someone doesn't have the money to afford their medications and their food, how are they going to improve those wounds? Certainly hydration is part of that. What kind of durable medical equipment do we have for that patient? Do we have an overlay mattress? Something to think about in your building block. What's your relationship with your DME provider? Do you have a really good relationship? Can you get that equipment out there quickly? Interdisciplinary collaboration. Are we working with PT, OTs, home health aides? And are we really talking about how to heal that wound as a group? And remember, physical therapists can do wound care as well. That's part of their practice act. So it's something to think about as we've kind of geared down in rehab, that maybe a PT might be someone that might do that wound care for you. And then lastly, using your home health compare scores to actually compare yourself to other people that may have a wound management program as well. As we go to our fast facts on pressure ulcers, and this will be my last slide before I introduce Shawn, we really need to get the basics and the facts of what pressure ulcers, pressure injuries are. And I have just recently learned that injury is the new word. So we're using pressure injury now instead of a pressure ulcer, which truly it is an injury. So I kind of like that we've changed that wording. Why do we really focus on these pressure injuries? Well, number one, there's about 2.5 million people in the US that develop these every year. They're quite painful. They impact the quality of life. They can certainly lead to sepsis. And there's at least 60,000 deaths a year from pressure ulcers. And a lot of these can be preventable. So making sure that we can heal these wounds and that we can get that quality of life back and we can prevent a sentinel event resulting in death is huge for our industries. Lawsuits is the second most common claim after wrongful death is pressure injuries. So there's multiple lawsuits around pressure sores. There's about 9.1 billion to 11.6 billion dollars spent per year in the US just on these pressure injuries, trying to heal them and the staff that's needed to provide care for them. And then estimate costs for hospital stays. If someone has a pressure sore, pressure injury, is about $43,000. So you can see that it's not just a quality of life issue, it's also a cost issue for Medicare. So therefore, having a very successful program really relates to that triple aim, right, for that quality improvement in those patient outcomes. So Shawn, I look forward to hearing from you and how we can avoid these pressure injuries.
Thank you, Tammy. So as Tammy stated earlier, pressure injuries are definitely one of the most common wounds that we do see in patients. And as you guys are able to see here on the slide, if you have patients that are compromised or they have a lot of functional deficits, it really increases their ability to get these pressure injuries. So from all the information that you have heard from Tammy, as you guys are building out your successful wound management program, please remember that an integral part of that success is going to be the clinician training. We definitely cannot overstress that. That is what will make us successful, the number one thing. So how can you be sure that your clinicians are receiving the training that's needed for them to be successful? Tammy gave some really good examples of using supply companies, WOCN nurses as an example. And there's just a lot of information out there, more information than what it was when some of us first came into home care. Things are just readily at their fingertips. But do the nurses know how to correctly identify tissue loss? That's going to be very important. They have to be able to know how to uh, look at these pressure ulcers and be able to stage them correctly. So, with every good wound management program, it begins with prevention. So, when the clinicians go out there, they do the Braden scale, they have to understand that they must perform a head to toe assessment on every single visit. And a lot of nurses need that reminder because there's nothing worse than having a patient to come on to our service and there's a stage 1 pressure ulcer, but we may not catch it. And we may do caregiver training, but the caregiver may not catch it either. And so, about the time anyone notices that there's a wound, then we are at another level. So, if we start with a stage 1, that is just simply redness over intact skin that doesn't blanch, such as you see here in this picture. Now, when we look at the stage 2 pressure ulcers or pressure injuries, I have to make myself continue to say pressure injury. Those have partial thickness tissue loss. So as you can see here from this diagram, there's a shallow open ulcer with a red to pink wound. Example here in this picture as well. Now, because there is no granulation tissue, you will not see any slough. Generally, it will just simply be red or pink, but you may see a blister. So a blister that is serum filled is also considered a stage 2 pressure injury. With our stage 3 wounds, these are considered full thickness wounds. So there's a loss of fat, and as you can see all the way here through the dermal layer, down into the subcutaneous tissue as well, sometimes, not always. This is considered a stage 3. As an example, you will also not see any bone, tendon, or muscle. You could see slough and you could also see eschar, but you will not see any undermining and you won't see any, you will see undermining and tunneling. It may be present, but it may not be present. With your stage 4 pressure ulcers, these are also full thickness wounds. But with these wounds, you're able to visualize bone, muscle, and tendon. So again, it's all the way through the dermis, through the subcutaneous tissue, and down to bone, muscle, or tendon. Same is here. Now, because there is granulation tissue, you may see necrotic tissue, but you also may see undermining and tunneling. A lot of times you will see undermining and tunneling with these wounds. With the unstageable pressure injuries, whenever the wound bed is fully covered with this necrotic tissue, we cannot stage this wound. So it could be slough, and the slough could be yellow, it could be brown, tan, but a lot of times when you have this black eschar, we have no idea how deep the wound is. So here, if you're looking at a heel as an example, you're able to see the eschar here at the top, but we don't have the ability to know how deep. So until the wound is debrided, either autolytically or mechanically, we can't stage the wound. Another wound that is unstageable is your suspected deep tissue injury. This is also called your DTI. So with the DTI, again, there's this dark purple or maroon localized area, and this is from pressure. A lot of clinicians are familiar with this type of pressure ulcer. Is usually a lot of patients that are in facilities as well, and you're trying to get the caregivers to float the hill. This is an unstageable pressure ulcer, and we don't know how deep that injury is as well. So before we go further, let's just test our knowledge. You can either put your response into the chat, or if you just want to call out the answer in your head, that's okay as well. But we're going to stage the pressure injuries. So looking at number 1, what stage is this pressure injury? If you said stage 2, that is correct. This is a partial thickness depth wound. So here you are able to see the red and the pink wound bed. So that would be a stage 2. What about number 2? If you said stage 2, that's correct as well. Here we have an intact serous filled blister, and this of course is related to pressure as well. And what about number 3? This is stage 2 as well. This is a partial thickness wound, and here you are able to see a red wound bed with greater than 50% epithelialization. Remember, stage 2 pressure ulcers do not heal by granulation. They heal by regeneration and epithelialization. And what about number 4? If you said unstageable or a suspected DTI, that is correct. And do you see the purple tissue at the bottom right? All right. So moving on, when we think about the OASIS, I know a lot of times when I am talking with clinicians and we are training on the OASIS, I try to get them to understand that the OASIS is a data collection tool. That's all it is. So Medicare give us rules on how to answer their data collection, but they need to think in terms of the physical assessment versus the data collection because there are some differences there. Medicare right now, as far as the OASIS is concerned, they capture data on pressure ulcers, stage 1, and then they separate that out from the pressure injuries that are stage 2 and above. And then we also collect data on venous stasis ulcers and the surgical wounds as well. But for coding, it's a little bit different. So how are you guys checking the coding compliance in your agency? Are you just assuming the field nurses are correct? And what are you doing to correct them if they are not? And are you reviewing all the wounds or just some? So these are questions that we have to ask ourselves as we think about our entire wound management program. So for the clinician in the field, they definitely need to document the site of the wound and ensure laterality is in place. Sometimes when we get our documentation from the physician, now if it's the primary diagnosis on your plan of care, you will have to have that wound identified in the physician's documentation. But if the doctor only states that the patient has a pressure injury, that is okay, as long as they say it's a pressure injury. Clinicians in the field have the expertise to be able to identify the laterality as well as to stage the pressure injury. And that's what we want them to do, but we want them to do it correctly. So we talked about stage 1, 2, 3, and 4 pressure injuries and unstageable. But again, when you're answering the OASIS questions, there are 3 unstageable items to code on the OASIS. One is the non-removable dressing or device is in place. The second is the wound bed is covered by slough or eschar. And the third one is suspected DTI. So on the OASIS document, we code one out of these three, but for coding purposes on the plan of care, it would just simply state unstageable. So we want to ensure that we explain in the documentation what those unstageable items are, since we're not coding those items. And then also remember, closed stage 3 and 4 ulcers are no longer coded on the OASIS. So we still have clinicians that are coding the closed, well, not coding the closed stage 3 and 4. On the OASIS itself, they are indicating that there's a pressure ulcer 3 and 4 because we were actually following that convention before OASIS D. So we don't do that anymore. Whenever a patient has a closed stage 3 or 4, we want to just simply put that information onto the plan of care and explain that it's closed inside of our documentation. In addition, for coding, you want to also include associated diagnoses or conditions that affect the wound. Does the patient have an abnormal BMI, for an example? Do they have any nutritional deficits? What about diagnoses such as dementia? Are they immunocompromised? Those are things that we want to ensure that we include. For coding other wounds, such as venous, arterial, and diabetic ulcers, again, that information is going to come from the physician and it must be included in the documentation. But clinicians must understand the differences in these wounds because the treatment for them can be different as well. So a lot of times, if the patient is coming from the wound clinic, then life is so much easier because you have your wound orders. But a lot of times, if they are being seen by a physician and they are actually looking for, for information from the agency on the best way to treat the ulcer, we have to have that expertise in our arsenal. And then what about the tissue damage? The nurses must know how to document the tissue damage. So the technology will help you with this because a lot of times clinicians don't understand the language that is there for coding, but through using technology, the information is there and all they have to do is select what they are actually assessing with the patient. There are items that we have to code first, and your coders are aware of this, but clinicians can have this information in their documentation as well to help to paint the picture. Other wounds that we will look at for coding are surgical wounds, your trauma wounds. I purposely place skin tears here because a lot of times in clinicians' documentation, they will code skin tears, but Medicare doesn't necessarily pay for skin tears. So a lot of times those skin tears will be coded as lacerations or trauma wounds. So again, Medicare pays for assessment and management of wounds. Inside of the technology, it gives clinicians the ability to identify what type of skin tear they're looking at. And you must identify, especially if it's a laceration or if it's an injury, what happened. So they can't just say that the patient had a skin tear and not be descriptive regarding a skin tear. A lot of times we will see skin tears, there's no skin loss, so that's a type 1, and the clinician is applying triple antibiotic ointment in a Band-Aid 7 days a week. If that chart goes through ADR and for sure through pre-claim review, you won't receive reimbursement. So it's important for clinicians to understand how to describe wounds accurately. Giving clinicians a system or templates on wound documentation, that's imperative as well, because what it does is it brings consistency and quality across your organization. So if they are documenting where the patient has been and they're also adding those social determinants, That helps to paint the picture for why the skilled care is needed in the first place. And additionally, if they are documenting the aspects of the wound, which includes the laterality, the site, the stage, and then also identify the functional status, things like the psychosocial status, the caregiver availability, all of those things are helping to paint the picture. And not only for the individual that's coding this patient encounter, but also for the auditor as well. A lot of times the auditor may or may not be a nurse. So when you put the information in your narrative and it's flowing to the plan of care, then there aren't a lot of questions to be answered because you're basically spoon feeding whomever is auditing the chart. Another thing is we need to eliminate variations in care in data collection. So this is one of the greatest advances of having technology, is because personalized care is dependent solely on the skills and the knowledge of the clinician. And you really don't want that, because variations in care is unacceptable and for a lot of reasons. One of the things is it can create risk for patients and providers. It increases your cost, it decreases value, and it also increases overutilization. Again, if everyone in the agency understands that we do not do daily wound care with triple antibiotic ointment and band-aids on uh, skin tears that are type 1, then you don't have to worry about things such as overutilization. Also, variations decrease your agency's competitiveness and your economic viability. And variations are not congruent with value based care. For sure, the practice of guessing is not a part of any healthcare model of the future. So, we talk a lot about standardization, and it's because we want to ensure compliance and that we practice best practice. And that is what technology and clinical intelligence is able to do for us. Now, one of the greatest things about standardization is wound measurements. Wound measurements are one of the most important aspects of assessing wounds. And this is where a lot of times we can get into trouble. So, staff must be trained properly how to measure wounds. It's important for them to be able to identify when the wound was last measured. Um, Basically, we want to ensure that they are measured at least weekly, more frequently if your policy requires it, but no less than weekly. When clinicians enter wound measurements, it informs the wound score. The wound score is vital for treatments and outcomes. If I know based upon the wound score that is entered into the system via standardized information, it will help me to know if that wound is healing, if it's declining, or if it's stagnant. And there is technology for measuring wounds. I know one of our partners, Swift Medical, via the mobile app, you are able to measure wounds. But if clinicians are using the standard wound measurements with the ruler, that's okay as well. But there's information on how to measure wounds. You'd be surprised to know that some nurses just don't understand how to measure wounds. A lot of clinicians may have not had wound care before they came into home health. I know that was my story. Several years ago, I came out of an ICU environment and we had a wound care team. And so I never ever had to worry about performing wound care, and I never did vac therapy until I came into home health. So being able to have easy access on how to measure a wound is also there when you have technology. Pictures. So we hear it said a lot of times that a picture is worth 1,000 words. And we can get so much information from just having good pictures. But prior to getting those pictures, we have to have consent signed. So we cannot have pictures inside of the patient's record and not have consent. I don't know any patient that would refuse to have pictures taken of their wounds. Some may. I've never had that to happen to me. But usually, once you explain the rationale, most of them are okay with it. So, taking pictures, however, on devices can prevent some HIPAA challenges. And many agencies have had to deal with that information being stored on their clinicians' devices. But it's important to have that picture at the point of care and to document what that wound is looking like. So even in this picture here, you're able to see over a period of time the healing and the progress of a wound. So you can use any iOS or Android phone or tablet, and from those devices, you are able to create awesome pictures. With the technology, if you use Axxess, those pictures actually are taken and go directly into the software. So you do not have to have them text or email and sent to someone in the office to upload. It will upload directly into the system. And that's definitely going to eliminate a lot of the HIPAA compliance or HIPAA concerns that you may have. All right, so let's talk about the documentation with technology. So when clinicians are in the organization, if they're all speaking the same language, then your reporting metrics are going to be easier to track. And I would say for those customers that are a part of the Axxess organization, what will happen is in a couple of weeks, we will release a wound manager report at no additional charge to our clients. And there are a lot of great things that you will be able to do with that report. For instance, if you are adding wounds, and I want to know as a part of a QAPI project, how many stage 2 pressure ulcers I have in my organization, and especially if any of those wounds developed on my watch, or how about if I want to know how many patients have a wound vac and whether the wound is healing or not, the system will give all of this information to me without having to call clinicians to get a report or digging through the patient chart to try to identify when was this wound last measured. It's very hard to do that without using technology and having a manual process. So again, every clinician in the organization, they're following the same process for adding their wounds, for adding their orders, and for documenting the wound characteristics. And because it's standardized and they're following the same process, all of this information is easily trackable. So electronic management further fosters standardization. I know you guys are probably tired of me saying that word, standardization. And I cannot stress the need for standardization, especially as it relates to quality clinical documentation improvement. Again, you're not depending upon the knowledge or the skill of the clinician. That's the important thing. A lot of times when we are talking about standardization, I like people to envision a pilot and a physician. And a lot of times I also have a video, well, not a video, but actually a screenshot of a physician and a pilot. And the question is, which one do you trust the most with your life? Which one of these people do you trust the most? And sometimes we get back varying answers, but the answer is the pilot. The pilot is the person that they follow a standardized way of ensuring that that plane is ready to take off and they have redundancies in place. Physicians is based upon the knowledge and the skill of that physician. I mean, they do call it practicing medicine, I'm just saying. But that's why standardization is just so important. So in the software with the wound management program, which is something that Axxess released, you are able to document varying uh, data points here, and it's all the same. So if the clinician is documenting, and for instance, if I say that my patient has wound drainage, then the system is going to say, okay, what kind of wound drainage and how much wound drainage? And then if I say that there's a large amount, then it's going to ask me even more questions. And it's not depending upon my knowledge, it's giving me the prompts to have clinical intelligence to enter what is necessary. So we talked earlier about stage 2 pressure ulcers not having granulation tissue. But many of you can verify that a lot of times when you are looking at documentation of clinicians in the field, they're always putting a percentage of red tissue for wounds, not realizing that there's no granulation tissue for stage 2 pressure ulcers. So the system will not allow you to enter granulation tissue. It also won't give you other data points such as undermining and tunneling. Unless that wound is a stage 3 or 4, it will not give you the ability to enter that information as well. Technology further streamlines documentation by keeping track of all the patient's wounds. So the system will keep track of all the wounds for an entire admission period. And it also ensures that all of your stage 3 and 4 pressure ulcers, that those may be reactivated in the system and that the wound numbers are not reused. And that is so important. It's hard to keep up with that manually, and it's definitely hard to keep up with that when a patient is readmitted for the third or the fourth time. So we can get reports and monitor, track, and forecast when we have standardized data. Wound orders are also present for each wound. So now you have great coordination of care. We all know that the deficiencies for wounds are always in the top 10 of deficiencies that are reported during survey. And so just having that ability to coordinate care directly in the hands of a clinician in the field is just absolutely wonderful. It gives clinicians a process to document, again, that does not depend solely upon their judgment. Another example of that is when they are restaging wounds. Clinicians often will backstage wounds, and that usually occurs when a patient perhaps came onto your service and maybe they had a stage 3 or 4 pressure ulcer and they are healing the ulcer. I mean, it's just doing well. And then we get to recertification, and at recertification, the clinician will now say it's a stage 2. And it's not a stage 2. It's still a 4. It's still a 4, and it's actually healing by granulation. So the system will not allow those type of mistakes to happen. And then validations to address all your wounds. That's important as well. So what you will see there is clinicians, maybe you get to the end of the recertification period and you discover the patient had a wound on the chart, but no one addressed the wound. Where the system, through validations, will ensure that all wounds are addressed on all visits, and also that you are able to track any wounds for which the care was not performed. Again, Tammy had talked about having WOCNs. Even if you had a WOCN as a consult, maybe you're not able to hire one, but even for consultation, it's great. Through technology, they are able to go into the wound history of a patient that maybe you want them to look at. They're able to look at all of the wounds that are attributed to this patient, if I want to, maybe this wound here, I want to look at the wound orders and see, okay, this wound is stagnant. So what orders did this patient have in the past? What do they have at present? And it'll help that WOCN to give a prescription for what should be there for the patient. Also, here is the wound gallery, so they're able to click here and see every single picture that's been taken for this patient. And if you click here on that particular wound, then they're able to see all of the individual visits. The wound scores, I was talking about that a few minutes ago. With the wound scores, you're able to see here, the higher the number, the worse the condition of the wound. And then once you see that number dropping, then you know the wound is actually heading in the right direction. And then again, with the wound orders management, here is where you are able to see all of the wound orders that are attributable to this patient's wound. You can look at the active orders. You can go here and see the discontinued orders as well. When we think about the process that clinicians use to determine supply choice for their wounds, the question is, how do they know what to look for in dressings? So again, that's where the education is going to come in, just making sure that clinicians are not applying, say, a dressing that costs $20 twice a day when the dressing could be changed 3 times a week. So that's going to not only save on the cost of supplies, but also the cost of visits. So are you guys utilizing your suppliers? Are you using a formulary? If not, why not? And just look at what type of benefits it can give. Again, it's a part of the standardization to just make sure that clinicians are thinking the same, and that they understand what is the best product for the wound type. Do they know when to use a calcium alginate versus a foam versus honey? Do they understand how to apply secondary dressings? Suppliers and vendors have a ton of resources for your clinicians. They have clinician playbooks. They have all kinds of materials where nurses can just simply say, hey, I have a pressure ulcer, or I have an arterial ulcer, or I have a venous stasis ulcer. And in those playbooks, they give them all the different types of wound dressings that they can use to treat a wound. And I would definitely say if you're doing daily wound care, that is for very, very special situations. And there are so many dressings out there that clinicians are able to use to just be more, I would say, to do better with their wound care and with the wound management, mostly with cost management. And then lastly, we want to look at coordination of care. So as you guys are starting to organize your thoughts about your wound care program, just keep in mind that coordination of care is very important as well. You know, how can you get the family involved, and what happens when the family doesn't want to get involved? Are you educating on the goal of wound care every single visit? Are nurses educating on the goal? And where are they documenting this? Are they documenting every visit if the patient is non-adherent? Again, in the technology, the system keeps track of patients that are non-adherent for things such as maybe they're not wearing their doing their compression therapy, or they're having issues with their diet, or they're not elevating their limbs, or they're not offloading. Maybe they're not following their physician appointments. So these things will impact the plan of care, and it's important to keep track of those items, especially from a QA/PI point of view. And then as it relates to your physicians and practitioners, how are you communicating with these entities? Are you just sending the office a message, or are you getting information for them? Through the wound manager and reporting, you will be able to give information very quickly. And are you getting your social workers involved in the aides and the therapy? Maybe the therapists are not actually providing the wound care. We know PT can, but they are a part of the care team, and they can help the clinician to pay attention to that dressing, especially if it needs to be reinforced. And then again, we just want to document. Coordination of care is also one of those items that we constantly get dinged for when we go through survey. So we want to just document all of this information. Hey, Tammy, I will turn it back over to you.
All right, thanks, Shawn. And I'd love to hear you present. Shawn is one of the reasons why Axxess technology and our system works so well. She started solutioning PDGM issues with wound therapy last year. Many of the things she talked about, she built into the system. So having people that have that operational knowledge, able to build in that visibility so that you can have all that clinical intelligence is huge. In today's time, it's not your same home health agency as it was 20 years ago. It's all about value-based care, and it's all about cost containment, because it's not just the fact that we have to heal the wound, but we have to heal it cost effectively. Seniors are population is the silver tsunami, the silver tide, the grand tsunami, whatever you'd like to call it. And along with that becomes a real strain on how we're going to staff it. So knowing and having that visibility, Shawn, I learn every time you speak. Thank you. You have definitely taught me things on this webinar, and we reviewed it before we got on the call. So just listening to you makes me think of other things to think about. So I hope it does the same with the people on the call. And I hope you guys really start thinking about how you can put a program together. Do you know everything related to wound care at your agency? Make sure you have that visibility and education. Go back through these slides and check off those building blocks that Shawn talked about. Next, make sure that you're efficient. Make sure you're using all the data that you have to make better informed decisions so that you can drive down costs. You know, do you have the most cost-effective vendor supplying your supplies? Are you doing that by drop shipment? And finally, once you know that this is something you want to embrace and really wrap your arms around, how are you going to grow it? Am I using a successful wound care program to gain more referrals for your agency? And how are you going to market that? Because I can tell you it's very marketable now. You saw the statistics. Wound care programs have not been growing. There's a huge space for that in the home health industry. And at the end of that, it's a patient outcome, which is why we all went into home health anyways. We want to improve those outcomes for the patient. So thank you. And Molly, I'll turn it over to you with a couple of minutes left.
Thank you, Shawn and Tammy, so much for sharing your expertise and your wisdom with us today. It was a great presentation. For all of you who join us, thank you so much for giving us some of your time today. And don't forget, we'll email a link to the slides and post a recording of the webinar as well if you'd like to share it with others in your organization. We will also post the recording and slides in the Axxess Help Center in the next couple of days. Thank you all for joining us today as we deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. Have a wonderful afternoon.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, Empowering care, anytime, anywhere.